Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Emergency Medical Treatment and Labor Act Update. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Karin Anderson, Principal, and Traci Waugh, Senior Manager at PYA.
Hi, I am Karin Anderson. I began my career as an oncology nurse. I've practiced healthcare law for about 25 years with healthcare corporations, physicians, and hospitals. And then I am very fortunate to be part of PYA's healthcare consulting team, where we all try to help providers, hospitals, and particularly today, we're focusing on helping with EMTALA compliance. Traci?
Thanks for joining, everyone. I'm Traci Waugh. I'm a senior manager with PYA, and majority of my career I spent growing up in the hospitals, in critical access hospitals, PPS hospitals, in a variety of different roles in health information, risk management, quality, medical staff, risk, and then, of course, with compliance. And today's presentation is near and dear to my heart, as I've lived through many different episodes of EMTALA studies and investigations, and we're happy to share with you today. So to start with, we're going to talk a little bit about just the basics of EMTALA today and some of the challenges that we're facing. Despite EMTALA becoming law back in 1986, not a lot has really changed with that. However, there's different rules and regulations that are changing, as we're seeing with Dobbs, that we'll talk about further in the presentation. So we'll talk about some of the basics, some things that you may have known, and just are reminders, and provide some checklists, and then talk about some of the different elements that are going into place today that we're having to experience.
So we thought we'd give you just a little bit of background of why EMTALA was even enacted. So before 1986, there was some research done that had reviewed records in the emergency room, and it found at the time that in hospital documentation, 87% of the patients were transferred to another hospital because of lack of insurance. And at that time, lack of insurance meant either they had no insurance at all or they had government insurance. And at that time, particularly, there had been a lot of cuts in reimbursement, something we are all familiar with. And then there had been a growing population of uninsured patients. So it had grown by about 10 million in 10 years. And so this had become a practice, is what the study found. And when patients were transferred, it was found that they were often medically unstable, and then their care had been delayed over 5 hours. So this got the attention of Congress. So in 1986, to prevent those issues, Congress enacted the Emergency Medical Treatment and Active Labor Act to ensure that there is access to emergency services for all those who seek it, regardless of their ability to pay. So Traci will talk about today sort of when EMTALA starts, when it ends, which is important to know. But its overall purpose is just to ensure that patients are not turned away or discharged or transferred because of their ability to pay. Traci?
Thanks, Karin. So as Karin said, we're going to further define EMTALA. So Medicare participating hospitals' responsibilities state a medical screening exam must be provided when a patient requests treatment, which includes active labor. So the requirements start when a patient either presents to a dedicated emergency room, which this could be an on-campus or off-campus, or an off-campus that is advertising that emergency treatment is provided. Also, if a patient presents on hospital property and is requesting an examination, is in a hospital-owned and operated ambulance, or is in a non-hospital owned ambulance is on hospital property. And so we're going to further describe, so that's when the requirements fall into place, but we'll further describe what a medical screening exam includes, who's a qualified medical personnel, and what an emergency medical condition includes. In overview, whoops. Hopefully you can probably hear my dinging. Once an emergency medical condition is determined, that's when stabilizing treatment needs to begin and or a transfer is instigated. And we have to remember that this will vary depending on the hospital's capacity to treat the patient, So the medical screening exam may be ongoing, treatment may be started, the patient may request to be transferred, or a transfer may be required because of the capacity of the facility that the patient presented at. So that leads us next to our very first polling question. Laura, if you will take that polling question for us.
Certainly. Thank you. The first polling question is, has your state law related to abortion, restrictions, bans, or expansions impacted emergency care services at your hospital? Yes, no, uncertain, our services are not covered by EMTALA, I am not a healthcare provider. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer.
So we do appreciate your input on the polling question because we're going to get into content, especially on how state law and EMTALA federal law are, reaching the news these days.
That's a good way to say it.
Thank you. And thank you for participating in our poll. Now I'll hand it back to our presenters.
Thanks, Laura. Okay, so we have a variety, some yes for sure, and then kind of a no or uncertain. So very interesting.
Yeah.
Great. Okay, so before we get into that some more, we're going to talk about the 3 tenets of EMTALA.
Let's see.
Are you advancing or what? Here we go.
Here we go.
All right, go ahead and go to the next screen.
Okay.
So,
sorry, it's a little slow. There we go.
That's okay. No problem. So
Okay.
I kind of like to look at EMTALA in 3 different steps. So we have the medical screening exam, we have stabilizing treatment, and then we have perhaps a appropriate transfer. And we'll dig into that a bit more. So if we talk about the first tenet, medical screening, which is the next slide.
There we go.
With the first tenet, medical screening, it may include not only assessing the presenting symptoms with the patient, but additional examination and testing that can occur because of the medical condition that's being presented. And what's important to also know is that the medical screening exam is to be performed by a qualified medical professional. Now, each facility needs to define who is considered a qualified medical professional. This can vary by scope of practice in your state, so you need to be aware of that. So it could be a physician, it could be an advanced practice practitioner, and it may be an RN, especially when it relates to labor and delivery. So what's really important to keep in mind is that you define who is a qualified medical professional for your dedicated emergency room or your facility. Normally, you find this in your medical staff bylaws, or it may be in hospital policy and procedure, but it's important to have that defined, and it matches the scope of practice for those providers. Then the emergency medical condition is determined if immediate treatment is not provided, the patient would suffer serious impairment. And for a pregnant person, that there is not adequate time to safely transfer before delivery, or transfer may impose a threat to the pregnant person or the unborn child. So with the screening medical exam, the biggest, important we need to keep aware is that we want to have no delay and no discrimination. And when I say that, it's like patient, you don't want delay to determine if the patient, if they have the ability to pay, if they have insurance, or you're grabbing insurance information. So there can't be delay with that. In addition, payers cannot be imposing prior authorization requirements for emergency care. What we also need to keep in mind is, there's no delay or no discrimination. However, reasonable registration processes may be followed, to including asking about insurance information, but it just can't delay treatment or discourage the person from receiving emergency care. And this should be closely monitored to see how that practice is being carried forward and that you're meeting those requirements. There are times that, of course, you need to do the bare minimum: patient name, date of birth, signs or symptoms, but you just need to get that initial registration started, but you just can't have delay or discouraging. And then again, pre-authorization is not to be sought after. Let's go back. You're fine. So things to remember about medical screening. Triage in your emergency room is not the same as a medical screening exam. Sometimes this can be misconstrued, where the nurse performs a triage and documents, the level of priority to be seen in the ER, but that is not what's considered a medical screening exam. So they have their own separate, distinct requirements and protocols. And it's not in your medical screening exam, it may be ongoing. It's just not a single snapshot in time for that particular patient. The medical screening exam is not requiring a definitive diagnosis, but that an emergency condition exists. And similar medical screening exams should be carried out for similar signs and symptoms. Again, as stated before, your medical screening may vary due to the capabilities of your facility. For example, a patient presents at a psych facility versus acute care facility. Those screenings are going to be a bit different because of the circumstances, but then stabilizing treatment needs to be provided to their capacity. Back to the qualified medical professional, along with bylaw designation. Keep in mind, again, that the scope of practice may be different for different medical professionals in your different states. So being aware of those state scopes of practice. And mental health and medical conditions may be presented at the same time and may overlap. Be sure to document care for each, and that there's a medical screening to address each particular situation. So on your medical screening exam, things to be aware of to prove evidence that that is being performed. Thorough documentation. You'll hear a theme from me about documentation. This isn't new to any medical professional. It's just worthy of always saying, because it's what will protect you in the end when there's a review done. But thorough documentation needs to be evident that in the medical record. For example, asking yourself, is there clear documentation of when the medical screening exam was started and when it was completed? Is there evidence that ancillary services such as lab and x-ray were performed to help determine if emergency medical condition exists? And again, are similar symptoms treated in the same manner? Next, we'll talk about the second tenet, which is stabilizing treatment. Again, wanting to have evidence of stabilizing treatment. Again, we refer to the capabilities of the facility and the staff. So it's very important that in the presentation of the physician and the specialist to the facility of when called and defined in the bylaws, rules and regs, or medical staff policies. So as far as the what a provider is called, that you document when the provider is called and when they are arrived. It's important to have those times recorded in the medical record. Now, there may be pre-established times for when a physician needs to present to the emergency room. For example, if you are a trauma facility, there's designated times of when a response time is required, or depending on specialties such as OB, the timing for a physician to present. So be aware of what that is. You have those defined in policy or bylaws, and then that would be something you would audit against. Communication is very important to continue between the clinical staff and your registration staff. As indicated prior, there's certain registration that can occur, but at what point in time can the registration continue and get additional insurance information if there's available, or additional demographic information? So that communication between the clinical staff and registration needs to continue on when registration can be allowed to come back and get some additional data. Again, then determining what stabilizing treatment is being provided and at what point continued care can be provided in a different setting, such as after stabilizing treatment, is the patient going to be admitted at the facility, or are they stabilized, can be discharged, and further follow-up needs to be done on an outpatient status. As the facility treating that patient, if you're going to recommend outpatient follow-up care, making sure that there's availability for that follow-up care, reaching out to that specialist, knowing when the next appointment can be, and helping along with that process. So upon discharge, it's very clear for the patient what the next steps are. And with that, again, discharge instructions, describing what the follow-up care is, and where that availability will occur. Further, we're going to talk about stabilizing treatment, and I'll hand this over to Karin.
See, there we go. So as Traci said, we've all been operating under EMTALA for a long time. So it's interesting, over the last year, it has really been in the news. And this is a little list of sort of, from the federal government's perspective, the messages they wanted us to get as healthcare providers. So a little over a year ago, Dobbs versus Jackson's Women's Health Organization was a U.S. Supreme Court case that overturned prior U.S. Supreme Court cases, and in essence stated that abortion is not a constitutional right, and so now handed it over to the states to say you have authority to legislate abortion procedures and services, whether they're offered or allowed to be offered or not. And so immediately, the 3 weeks following that opinion, the federal government who enforces EMTALA wanted us to know a few things. And one, it started with the president, who issues an executive order directed at the Health and Human Services and says, I want you to report back in 30 days and tell me all the steps that you're going to take to protect pregnant women seeking emergency care or women that are in the process of a pregnancy loss. HHS responds within 3 days and sends a letter to all of us, all healthcare providers, and says EMTALA, in short, will be followed, and encourage and states that EMTALA is always going to preempt state law. Now, stay tuned. We're going to talk about that in a minute, but it says EMTALA will always preempt state law, and what preemption means is that state law is going to yield to federal law when it's impossible to comply with both laws. So federal law will be the one that you follow. Specifically, HHS, when they sent that letter, said, let me also point you to this guidance that we give to surveyors, which a lot of us read, which was from 2021. And it was specifically guidance on patients who are pregnant, experiencing pregnancy loss. We highly recommend the sites on the next slide that you read that one, because it is very specific to diagnoses and treatments that are expected or acceptable. But in this HHS letter to all healthcare providers, they said if a patient with an emergency medical condition requires an abortion as medical treatment, to stabilize the patient, an abortion must be provided. So that is very clearly the message that we have received, is that EMTALA is going to be enforced, is going to be followed. And we wanted to give this presentation today because we think it is very top of mind. We keep getting the same messages from CMS and keep seeing alerts about this. So we thought this was a really good time to kind of go over compliance requirements for EMTALA so that everyone is ready. So still on stabilizing treatment, that specific, which is referenced here, the state surveyor's memo, says a couple things, reiterates the messages that when state law prohibits abortion, or your state law does not include an exception for the life of the pregnant person, or it draws an exception in state law more narrowly than EMTALA's definition of an emergency medical condition, the state law is preempted. And in essence, they view that as a direct conflict existing between EMTALA and the state law, and that EMTALA must be followed. They also remind us in that memo that there's a whistleblower provision. So if you're an employee of a hospital or a physician and you refuse to transfer a patient saying they're not stabilized and they have an emergency medical condition, they give examples of emergent ectopic pregnancies, then for filing a complaint, you cannot, you would be protected, you would not lose your job. So those are, again, just sort of the messages that we are hearing from CMS. So over the last year, lots of changes. And so when that U.S. Supreme Court case changed, all the states have been very busy. Some states have complete bans on abortions. You can see from this map, there is a variety. They might completely ban abortion, that it's no longer legal. They might have used the prior sort of criteria that we relied on for gestational limits, that they are permitted up to a certain gestational period. They may also, we've seen in some states, there's really an expansion of abortion services, and they're really just sort of making it clear that there would not be provider liability in those states for providing a necessary abortion. So we are also seeing kind of all over the map litigation in these states. So you'll see some of our notes, like 5 of the state bans were actually blocked. So people are filing, as we've seen in the news, lawsuits about that. So the point of this is just to say, we have to know EMTALA. You also have to know your state law. And we'll talk about that a little further, but definitely you want to know what the exceptions are. If there are documentation requirements for those exceptions, you're going to want to incorporate that into your own policy at your facility.
And just to add to that, when you look at that map,
Here, I'll go back.
knowing what your neighboring state's state law is and how is that going to impact you. If you're next to a state that has a complete ban and you have different limitations, there's going to be cross the border treatment going on. So it's important to know, what your impact could possibly be because of that.
And Traci, that's a great point too for patient education. So a patient comes, across the border, just 15 miles away, and they have some thoughts about what their state law is, but yet they're in another state receiving care. So you may have to explain our policies and what we're doing a little bit more, just so that the patient doesn't have a misunderstanding. That's a great point. Okay, and then this is just not to make this legalistic, but as we said, there are two prominent lawsuits right now that have been in the news a lot of it, and we just want to touch on them. And this is really sort of the fight between, does EMTALA preempt the state law? We have two cases. Texas was last year sort of in the news, and Idaho is this year in the news. And those are in active litigation, so the lawsuit's still going on, but in both cases, there's a temporary court order. And the court in Texas said, hey, CMS, you cannot enforce EMTALA. We do not agree that overrides Texas state laws. And so temporarily, you'll see it on the state surveyor guidance. They'll be in red, except for Texas, all of this applies basically. Idaho had the opposite happen. Idaho state law went into effect, and this was challenged, and there's a temporary court order that says Idaho state law can't be in effect, that EMTALA is considered to preempt that. And again, those will both be fought out. If you're in those states, I'm sure you're following it, but those are ones that we are all looking at, and just shows you the importance to know the state law and then just kind of follow along in the news as to what is going on and what you need to do. Okay, so EMTALA enforcement. So the hard part is, okay, so that's great. All these crazy things are going on, but what do? We're a hospital, you're a physician, you're a qualified medical professional, and you're in charge of the ER. So you're stuck in the middle a little bit. So what we would recommend, we've talked about before, is first, think about, will abortion procedures provided to stabilize EMC cause a provider to violate the state law? So to do that, you've got to know your state law, kind of in and out. Be aware in your state law what the penalties are. Some laws are civil, some are criminal, so which would mean the punishment is actually prison time. This is not to scare anybody. Fines. It also can be reported to the state medical board for your medical license. So very serious laws that you're dealing with, all the more reason to know. One source that Traci and I would recommend is look at, if you're an emergency physician, look at the position statements that are out there for the American College of Emergency Physicians, OBGYNs, look at ACOG. They have great position statements and practical tips on really how to, continue to proceed clinically, which is so hard when you're in the middle of kind of legal issues, but to proceed with your clinical judgment and then document appropriately. And then the other thing, as we've already said, is really just clearly document very clearly the emergency medical condition, document your findings, document anything that's required by state law, and just if you're taking sort of that extra time to do that, that should help a long way. And as we said, the medical screening exam, patients change, right? They come in with one condition, their condition becomes very critical. Just, as always, documenting that along the way will help. I think Traci already covered that last point. Okay. So this is a little bit of a repeat, but we wanted to say sort of best practices, which we'll talk about throughout this, is really kind of having an audit tilt. So know your EMTALA, know state law, kind of make sure your policies are up to date on all of that. Train your staff on those policies. What was my other point? Sorry. And any clinical protocols that you feel like you need to have, just look at that. And an audit tool is always helpful on the basics of EMTALA, just to periodically audit yourself on compliance. Polling question number 2.
All right.
Thank you. The second polling question is, who decides if a patient may be transferred from the ER to another hospital? The patient, the physician, the receiving hospital, all of the above, or none of the above? Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer.
And remember, don't worry about having a wrong answer. No one knows who's answering what. This is all for your CPE, and we'll be talking more about this in a bit.
A good point. I don't like being quizzed before somebody's told me the answer.
Right?
Yeah, that seems unfair.
Thank you for participating in our poll. I'll hand it back over to our presenters.
All right, great, thank you. So we have a few for physician, receiving, and then all of the above. Great.
That's
so
perfect.
Let's go ahead and jump to the next slide. And so we are going to now talk about the third tenet of EMTALA, which is transfer. So to cover some of the information that was just talked about. So when is a patient to be transferred, and when is the right time? So in this visual, you can see that you provide treatment to minimize the risk of the patient or the health of the unborn child, but the steps that you need to take. So you may determine that as a facility, you may determine that the care that's needed to be provided is beyond the capabilities of your hospital. So that would be one circumstance where you'd recommend transfer to another facility. And that would be a determination that the physician has come to. The other is the patient may come to the perspective of, I want to be at a facility that's closer to home or somewhere where my provider is. So the patient may request that transfer. And then, of course, ultimately, the receiving facility needs to accept the transfer. So in the slide prior, the answer is truly all of the above because of all the different steps that need to be taken. So when that decision is made that a transfer needs to be done, you need to contact the receiving facility. They need to be able to have the space, the personnel, the capability to take care of that patient. And then they have to confirm if they can meet all those obligations to you. Then the sending facility has to make sure that once they've confirmed acceptance, that the medical record is sent and made available for the receiving site. And then arrange, of course, for appropriate transfer, be it in ambulance or whatever's the appropriate method of transfer to reach that facility. Again, making sure that all these steps are documented in the medical record, that they have all been taken. A lot of facilities come up with a form that has all those sections distinctly spelled out, so it's easy to document and capture all that. So that's always something that's helpful to have. So for accepting transfer, a hospital may refuse to accept a transfer of the patient. It may be because they don't have the capacity to treat that patient. One example is perhaps you have one neurosurgeon, and that neurosurgeon is on vacation, that are not available for call. And in this particular situation, you may not have the capacity so that you can't accept that patient. or if the facility is truly on a posted that they're on diversion because they're full at capacity and cannot accept another patient's. It's important to know that once a patient, if you're the receiving facility, the patient comes to the ER, you've gave them stabilizing treatment, you've determined to admit them into your own facility, and at this point they're an inpatient, and then later you decide, you know, they do need a transfer to another site, the EMTALA obligations have stopped at that point when the patient has become an inpatient at your facility. So those requirements of accepting transfer are not still evident. So it's important to know that EMTALA does end at point of admission. So next we're going to talk about some regulatory checklist information that would be probably helpful for facilities to keep in mind. So we'll start with on-call. So on-call, it's important to know that you have an on-call physician, that you maintain a list of those on-call physicians. And it can't be just, you know, the orthopedic group. Truly on your on-call list, it needs to indicate who is truly on call. The hospital may allow an on-call physician to schedule elective surgery while they're on call, but there must be a planned backup should the need arise while that person's in the surgery. Also, in certain circumstances, your on-call physician, your hospital may decide that that physician can be on call simultaneously at 2 different facilities, depending on that proximity. Again, if that's the case, there needs to be a backup plan in place if those services are needed. What's important too is with that on-call list, that the on-call physician's keeping the emergency room apprised of their status, so that they give notification, hey, I'm going to be in elective surgery from, you know, this time to this time, so that the emergency room is conscious of what is going on and what their availability is. What's really important too is for that on-call physician, if the ER doctor wants that on-call physician services and they call and say, I need you to come to the ER and see the patient, they are required to come in. The ER physician is sort of the captain of the ship. So if they feel as though the provider needs to come in and assess the patient and provide treatment, that on-call physician is obligated to come in. It's up to that, again, that ER physician. If they feel a verbal consult over the phone is sufficient, that's the position of the ER physician. Again, the documentation is so important. Be sure that you document the time the on-call physician was called and the time that they responded, either by phone call, if that was the case, or in person, because you want to be able to have that captured in case you need to go back and audit and see, are they meeting your requirements for responding in a timely manner? Next, how often must a physician be on call? Now, the frequency for this can vary, and it is established by facility, and it could be defined by the specialty, and it could be defined, you know, if you're, again, like I said before, if you're a trauma certified facility, there will be certain requirements of what you have to have in place. But, you know, you should have it defined in your bylaws so that a physician that becomes on the medical staff knows what the expectation is. Or if you have contractual arrangements for physicians to be on call for the emergency room, that it states in their requirement. You know, back in the day when I was practicing with medical staff services, we always sort of in our bylaws had a statement that if we had 3 specialists, say we had 3 orthopedic surgeons, that we'd have the whole month covered because each orthopedic surgeon would take 1 week of call. If we only had 2, then only 2 weeks, and we may have 1 week that's uncovered unless other circumstances were made to schedule for those arrangements. So you should really have those pre-established. And again, very important for the emergency room to know what the status is of their on-call providers. Gone are the day that a single surgeon is going to be required to be on call 24/7. Those days are way gone. So just make sure that you have that defined in your bylaws. So next I'll pass over to Karin to talk about patient refusal.
Yeah, go back one. There we go. Okay. Yeah, so I think, again, in this regulatory checklist, one thing that's important is the patient refusal. So the patient comes in, seeks emergency treatment, but of course, once we explain the treatment that is needed, or even that the exam is going to be done and what it might require, or that we're recommending transfer, patient has a right to refuse any and all of those. So what should the hospital do to make that clear what has been done? So a hospital should document that exams were offered, that certain treatment was recommended or transfer was recommended, and why. In the medical record, if the patient refuses, you're going to document the refusal and any specifics about that. You definitely want to document, because this is part of an EMTALA requirement, and we know it's general informed consent requirements too, but that you explained the risks and the benefits to the patient. So the risks and the benefits of transfer. And again, when they're refusing, really the risks to refusing treatment, to refusing a transfer to perhaps a hospital with more capabilities. All of you likely have forms about, AMA, written informed refusal of the treatment, the exam, or whatever. You want to present that to the patient, but we know sometimes patients won't sign. Simply document in the record the steps that you took to attempt to get that signed, that it was presented to the patient. Again, the information was gone over with the patient, and add that to the record if they won't sign. One thing we would note here is simply to be really not generic, be specific and individualize it to that patient. So the risks and the benefits to that particular patient based on their condition. And so not just have sort of generic language in the form that you use for everybody. And then the other thing is signage. We talked about that. This is just a requirement of EMTALA. The patient's EMTALA rights have to be posted conspicuously and in certain places. So definitely the emergency department, definitely labor and delivery, and then areas where a patient may wait for examination or treatment when they're seeking emergency care. I think we may have touched on this, but like you could have a psychiatric patient that is used to coming to psychiatric outpatient, and they really present to the outpatient psych area, but they're in an emergent state. So that might, just depends on your hospital, but that might be a place you would consider signage. And these are sort of just some things to think about when you're like, do I have all the signs in the right place, at each entrance, where patients might be coming in to seek examination and treatment, identify all the right departments for that. Are they posted in a registration waiting area for that department? Are the signs visible from about 20 feet? Are they in the right languages for the population that we serve? And then is there a process for checking on signs? And that's just our reminder to you, again, what we talk about an audit tool. So if I'm self-auditing, what are some things that I need to go around and do to verify that I'm in compliance? And this would be one of them. A central log is another in your regulatory checklist. This is another requirement. You've got EMTALA requires that you maintain this log for every patient that's seeking emergency treatment. And then there are certain categories listed here that each patient, the outcome with that patient is going to be listed. And those are the categories on your log. And I know all of you have that. See, Tracy, next one's to you.
Yeah.
Let me get.
And just to carry on with that central log, there is a record retention requirement, and that is a 5-year retention with that log, with all those elements that Karin just talked about. And remember, we're talking, we tend to focus on the emergency room, but if you have OB patients that are presenting directly to your OB ward, they too need to be maintaining a log, a central log that indicates those same elements of treatment, if they were discharged, if they were admitted, and so forth.
That's a great point.
And then next, we'll talk about there's policies, of course, that we've been touching upon. So Karen, I'll let you take the next slide.
Okay. Yeah. So one of the things we would say about your policies, it's that the definitions are important, right? Emergency medical condition, medical screening examination, qualified medical professional. Those are not terms used, just hospital wide. So you're going to want to clearly define those in the policies, so that everybody knows what you're talking about. Part of the policies, it's important to know, when does EMTALA start for us? When does EMTALA end? So you understand when this policy applies. And then all the specifics we've talked about today, hospital property, when has someone presented to the emergency room? Where could they be? There have been prior things about being in the parking lot, and have they presented to the hospital, that kind of thing. So just make sure all these things we're talking about today are included in your policy. And then, of course, when you have a policy, it's useless if you don't train. So EMTALA has something to say about training as well. They want to make sure that you train all the staff that might encounter a patient seeking emergency care. So just always think about your staff as like from the beginning to the end of the process. So registration clerks, triage, nurses, physicians, other practitioners, and then anyone designated as a qualified medical professional. And then also think about, well, which departments do we need to do that in? We talked about psych outpatient might need to be trained, as well as labor and delivery in the ER. And then how often do we do the changes? We know this, right? Whenever there's a change in your policy, your protocol, or your state law, which is happening pretty quick right now. Also, whenever you've had an issue, we all know when we've had an issue identified or there was some confusion and we've got some lessons learned, that's a nice time to trigger a retraining. And then always have this on your training schedule as routine. EMTALA for the ER staff certainly needs to be a routine, on a routine training schedule. And then always train against your policies, which usually will include the EMTALA requirements. And then also, like we said, train on, if you've got some findings of your own internal audits, things you want to stress, always add that as well.
And Karen, I like always to stress too, we talk about the emergency room, but that registration staff, making sure that they are kept current on what their requirements are and there's no confusion, and that, again, that communication between the clinical staff and registration remains strong.
That's great.
So this is one of my favorite slides, just kind of a decision tree for EMTALA, and when EMTALA applies, when it doesn't. So as you can see, it's a really nice graph to ask yourself, okay, so the person presented on hospital property, it does, and when does this apply? And just follow the grid to know, where do you stand with that particular patient? And as I talked about, before, where does it end if the patient's admitted or when they're transferred? So this is a really nice visual to make available to staff to think through and ask questions. So I think we'll go on.
I wish I had this in the past, Tracy, I'll tell you.
Yes. So the next slide talks about hospital obligations, which we've really talked about and was just a summary. I think due to time, we'll go ahead and jump to our third polling question. Mm-hmm. So Laura, if you wouldn't mind, go ahead and taking that.
Certainly. The third polling question is, how does CMS enforce EMTALA? Investigations and surveys, threat of financial penalties, threat of termination of hospital's provider agreement, or accepts complaints, or all of the above. Remember, you must fill out the polling question in order to receive CPE credit. You will have 30 seconds to answer.
And we tend to rely a lot on our acronyms, but of course CMS, I'm sure you all know, is the Center of Medicare and Medicaid Services.
Good point.
Thank you. And thank you for participating in our poll. I'll hand it back to our presenters.
Excellent.
A plus.
Excellent. Yes.
That's
all right.
great.
Yes. Okay. Let's see. I think we can move on a couple slides and talk a bit more about the enforcement, Karin.
Okay. And I'll go quick, folks. Let's see. Hold on. There we go. Okay. So this is just, okay, so we never want this to happen, but if it does, and it looks like there's been an alleged, I always say alleged because I'm a lawyer, violation of EMTALA, or someone has filed a complaint alleging one, then this is we wanted to go over just briefly the process. So there would be a complaint filed. You will see that you can go to the CMS website. It will very clearly direct you where to file a complaint, and you do that with each state survey. So unfortunately, it's very easy for someone to file a complaint. And this is a complaint-driven process. The next step in the process is the CMS will determine if the complaint meets the criteria for an on-site survey. And if it does seem to, by the facts, allege a violation of EMTALA, then they will proceed to further investigate, including a survey. We'll talk about the details in a minute. Once they finish the survey, if there is a deficiency, they would issue a statement of deficiencies. That's telling you these are violations of EMTALA. We expect you to fix them. The hospital's job is to respond with a plan of correction. CMS's job is to approve or disprove the plan of correction, but get you to come up with one that's going to make sure that you've prevented that violation from occurring. And then they will come back and resurvey to make sure that things have been implemented. So that's generally the process. We wanted to heighten this because in May of this year, there was an announcement again by CMS that said we're currently investigating 2 hospitals, and it's over sort of what we talked about before, the issue of state laws coming into effect, EMTALA, and you know, whether the hospital proceeded correctly in the care, emergency care for a pregnant patient. So again, this unfortunately can happen, and HHS has said, as a reminder, when they announce those investigations, you are obligated to offer necessary stabilizing care to your patients, and we will not hesitate to enforce your obligations under the law. So the message is clear. We're hearing them. So when you have a suspected violation, and maybe again just something has happened in the ER internally, or you've heard that a complaint has been filed, let's say, but go ahead and internally investigate. And Traci, by all means, jump in here. But you want to always, whenever you have an issue in the hospital, internally investigate yourself, identify if there has been a problem, and if so, go ahead and take corrective action based on what your own findings are. That's the best thing that you can do, is immediately resolve an issue. And you're going to review policies and procedures. Again, we talked about maybe that's retraining, maybe disciplinary action is warranted. And again, use your audit tool of just your general, you know, EMTALA compliance. Is everything in order while you're taking a look at this? And I'm going to go pretty quickly through this. Complaints are anonymous. They won't tell you who has complained, but it could be a patient family, it could be an employee, it could be another healthcare provider. And there's one group that a receiving hospital is mandated to report within 72 hours if they suspect they have received an inappropriate transfer under EMTALA. So there is one complaint that is mandated. And if they don't report, the receiving hospital, their CMS provider agreement is in jeopardy of being terminated. So they do report, as many of you know. The survey, just again, real quickly, the purpose is to ascertain if there's an EMTALA violation. The survey they do not stick just to the incident. They're going to look at everything to see if you comply with EMTALA. They are looking to see if any violations constitute immediate jeopardy. We'll talk about that definition in just a second. They also look back at your history. Has your hospital been reported several times before? Have you had corrective action plans before? That weighs into their thoughts on compliance. And three things are gonna happen. The survey will be a medical record review. They'll take a sample of patients, and Tracy reminded me before we started that one of the patients they will pick is probably the one that's at the heart of the complaint. So they'll be reviewing that record in full. They're going to interview staff. They're going to talk about, to the registration clerk, to the physician. They'll interview whoever they need, and they will ask for lots of documents, all the kinds of things we've talked about today, from policies to your central log, to your medical staff bylaws, on-call physician schedules. So they're going to ask for lots of things. Let's see. The other thing to remember, in that state surveyor guide, there's 4 Medicare conditions of participations that they believe are very relevant to emergency care. And so they're looking at those as well. And again, as a follow-up, you've got the site to that one in the slide, but it cites the 4 conditions of participation to look at. And again, going quickly here. So they do the survey. After the exit, they do an exit interview with you, and within the 30 days, if there is a violation, they will send you a statement of deficiencies. There's 2 tracks. You're either sort of on the fast track, which is 23 days, which means they do believe there's an immediate jeopardy from the violation, and that means that it's a situation in which the non-compliance has placed the health and safety of recipients in its care at risk for serious injury, serious harm, serious impairment, or death. And so the short time frame, of course, is to correct it immediately. They don't want that situation or environment to continue. If you're on the 90-day termination track, that is a non-immediate jeopardy. You've got a little bit longer to correct things. The reason, and again, what's in play here is the 2 penalties really are termination from the Medicare program and fines against the hospital and providers. So we want to make sure we respond to that correctly, and that's with your plan of correction. You'll get the deficiencies. Within about 10 days, you're going to respond with the plan of correction. And again, CMS has to approve that your plan is appropriate. And sort of 3 things are pointed out here is, number 1, the plan will correct the violation. Number 2 really is it'll prevent the violation from happening again, and it's going to ensure that we continue to comply with EMTALA. And then really you want to show that you're going to self-audit from now on. No one has to complain about you, or no one has to check on you, that you're going to have your own plan for making sure that you stay in compliance. And then finally, when the plan of correction is accepted, they will re-survey. And as we mentioned before, they're never limited to just what your plan was. They can look at other things. So whenever they're in the door, they're looking really kind of at all of your EMTALA compliance. I think, and then we do hate to end on a bad note, but this is a little bit negative. So termination is very rare. That's the first thing to say. That's one of the tools in their toolkit that you're threatened with if you're not compliant with EMTALA. If termination does happen, the appeal, we did note the appeal process, there is an appeal process, but it is lengthy and it is not very quick. So we want to make you aware of that. So the key is to just always handle it within the survey, do a good plan of correction, work with your state surveyor, and fix things, which is what all of you do all the time. You're very used to that. The bigger thing that usually happens with an EMTALA violation is that there are fines, and they're called civil monetary penalties. They can be placed on the physician and on the hospital. If you have over 100 beds, a hospital can be fined up to $119,942, and this gets changed with regulations every year. And physicians that have a gross violation or repeated violation, can go up to the same level. For physicians, also know that they can be excluded from the Medicare Medicaid program by OIG. And again, these kind of assessments or penalties can get reported to the state licensure board. So then the physician might have to deal with that process as well. So what we would say is generally with those kinds of, knowing it's a serious issue, just making sure, as always, that you're preventative. Have your audit tool where you're self-auditing, make sure your policy's up to date, train your staff. That could probably one of the most important things. And then we've listed some of the resources here that we used for today, but by all means, email us if you need more information or re-reference something that that we don't have on the list. And I think that's it. Thank you all so much.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.